So today we'll begin a simple primary care review on type 2 diabetes in children. Incidence rate of type 2 diabetes mellitus has increased in children and adolescents. Type 2 diabetes mellitus in children is linked to childhood obesity and is also a risk factor for vascular disease later in life. Overweight or obesity, positive family history, specific racial and ethnic groups such as Native American, African American, Hispanics, Asian American, and Pacific Islanders, as well as the female gender. Clinical presentation. For asymptomatic, a patient may test positive for type 2 diabetes mellitus because of risk factors or through a routine physical examination. Symptomatic would show polyuria, which is frequent urination, polydipsia, increased thirst, polyphagia, always feeling hungry, nocturia, and fatigue. Laboratory testing, hemoglobin A1C. A1C is a screening test for diabetes mellitus. If A1C is greater than or equal to 6.5% on 2 occasions, it is a diagnosis of diabetes. If A1C levels are between 5.7 and 6.4%, it indicates prediabetes. Fasting plasma glucose. If FPG is greater than or equal to 126 milligrams per deciliter, it is a diagnosis of diabetes. If FPG is greater than or equal to 100 milligrams per deciliter to 125 milligrams per deciliter, it is known as prediabetes. Oral glucose tolerance test. The glucose load used for the oral glucose tolerance test in children is 1.7 grams per kilogram, up to a maximum dose of 75 grams. If plasma glucose is greater than or equal to 200 milligrams per deciliter, measured 2 hours after the glucose load, it is a diagnostic of diabetes. If plasma glucose is from 140 to 199 milligrams per deciliter and measured 2 hours after the glucose load, it is known as prediabetes. Further laboratory testing. Laboratory testing to rule out type 1 diabetes includes a panel of pancreatic islet autoantibodies, insulin and C-peptide levels, venous pH and urinary ketones. Prediabetes. Prediabetes is caused through an increased risk for developing type 2 diabetes mellitus. Hemoglobin A1C values are between 5.7 and 6.4%. Fasting plasma glucose is from 100 to 125 milligrams per deciliter, and plasma glucose from 140 to 199 milligrams per deciliter, measured 2 hours after a glucose load of 1.75 grams per kilograms in an oral glucose tolerance test. Pre-diabetes follow-up. Annual rescreening for type 2 diabetes mellitus is recommended or sooner if there are changes in weight or other signs. Diabetes diagnosis. Diabetes is diagnosed based on one of the following. If hemoglobin A1C is greater than or equal to 6.5%, if fasting plasma glucose is greater than or equal to 126 milligrams per deciliter, and random venous plasma glucose is greater than or equal to 200 milligrams per deciliter in a patient with classic symptoms of hyperglycemia. If plasma glucose is greater than or equal to 200 milligrams per deciliter, measured 2 hours after a glucose load of 1.75 grams per kilogram and an oral glucose tolerance test is also a diabetes diagnosis. Management: non-pharmacologic therapy. Weight reduction. The optimal goal is a 7 to 10% weight reduction. Weight loss reduces insulin resistance and improves insulin secretion. Physical activity. An increase in physical activities. Engage in moderate to vigorous physical activity for at least 1 hour daily, with strength training at least 3 times weekly, as well as decrease in sedentary behaviors. Dietary treatment. Dietary counseling is recommended, which focuses on a gradual change of family and individual dietary habits to better achieve long-term goals. Decrease portion sizes. Substitute a fruit or vegetable for a carbohydrate-rich food. Decrease or eliminate high caloric beverages and replace them with water or calorie-free beverages. And reduce the frequency of eating out and increase family meals at home. Pharmacologic agents include metformin, insulin, and liraglutide, which is a glucagon-like peptide 1 analog. Thank you.